Hello and welcome back. Today we'll discuss migraine and what Harrison has to say about it. Migraine is a part of primary headache disorders that includes tension type headache and TACs, which is trigeminal autonomic cephalgias. So basically, primary headache disorders are headaches with associated features which does not have any exogenous cause. So basically, migraine is the second most common cause of headache after tension type headache. And also, it is a leading cause of headache related neurologic disabilities worldwide. It impacts females more than males. It is a type of episodic headache with its associated features such as nausea, vomiting, photophobia, phonophobia, and scintillating scotomas. Altogether, migraine occurs in three phases, which are three phases includes premonitory, which is prodromal stage, headache phase, and postdromal phase. Prodromal or premonitory stage includes neck discomfort, which includes brain fog, meaning the patient loses its comprehension to the environment. So, for example, there is a lecture going on, and a student feels that he is not able to attend the lecture with full attention and full comprehension. He feels as if he is not in that place exactly, which is brain fog, mood changes, fatigability, homeostatic features such as yawning, sleepiness, food cravings. These are all the premonitory symptoms. Then migraine headache phase. Headache phase includes the pain, nausea, vomiting, and sensory sensitivity features such as photophobia, phonophobia, osmophobia, allodynia, and vertigo. It is interesting to note that vertigo, one third of the population with vertigo are primarily diagnosed as migraine vertigos. Such is the association of vertigo with migraine. And the third, lastly, is the post-stromal phase, which includes tiredness, weariness, and concentration impairment. In some individuals, approximately 20 to 25% of the people, there is also a fourth phase, which includes aura. Aura, particularly neurological disturbances such as scintillating scotomas. This is how a scotoma will look with zigzag lines and visual disturbances. So, for migraine, sensory sensitivity is the characteristic of migraine. We'll understand this in pathogenesis part. But before that, we must recognize the triggers which leads to migraine. The first and the foremost, which Harrison says, is altered sleep patterns, hunger, physical exertion, stormy weather, barometric pressure changes such as high altitudes, hormonal fluctuations, as in case of females, alcohol, and any chemical stimulants such as nitrates. So, for managing patients with migraine, we must take a detailed history with regards to triggers and include them in the lifestyle modification part. Pathogenesis. So, pathogenesis of migraine has multiple wings. One such, our star molecule is CGRP, calcitonin gene related peptide. Another star molecule is our serotonin, which is 5-hydroxytryptamine. The third is dopamine, and also genes are involved. So make sure there is a family history of whenever a patient presents, you also take a family history because genes are associated with development of migraine. As I said earlier that migraine has a sensory sensitivity. Hence, the cycle of migraine, the pathophysiology of migraine starts with dysfunction of the monoaminergic system in our body. So basically, monoaminergic system plays a crucial role in filtering and processing sensory information which our brain receives. Hence, which leads to neuronal excitability. So, whenever there is an activation of cells in trigeminal nucleus, So see, trigeminal nucleus, which is present in our brainstem, has three branches: ophthalmic branch, maxillary branch, and mandibular branch. So trigeminal nerve altogether is a mixed nerve, taking sensory information from the face and the head region. Okay. So if because of the dysfunction of the monoaminergic system, I'll write it down here. Dysfunction of monoaminergic system. Okay, leads to activation of cells in the trigeminal nucleus, releases vasoactive peptide, again our star molecule, which is CGRP, at vascular terminals of trigeminal nerves. As we have learned in our past lectures about pain, wherein the free nerve terminals of any nerves can act as nociceptors, so the nerve terminals supplying the cranial blood vessels are getting activated, leading to pain sensation, which travels up to the thalamus via the second order neuron. Again, thalamus is our relay station. Any sensation for a particularly pain relays in our thalamus. Then from there third order neuron starts, which ultimately ends into the sensory cortex, and the patient perceives pain. So for the management of migraine, we must have drugs acting on the CGRP pathways. The second part is the serotonin. It is a pharmacological theory wherein the release of serotonin leads to vasodilation and plus stimulation of the trigeminal nerve endings. Again, the same way. Therefore, again, for the management of acute attacks of migraine, we have triptans, which are partial agonists of 5-hydroxytryptamine 1B 1D receptors, arresting the signaling at trigeminal nerve endings, also vasoconstriction, and leading to pain relief. The third mechanism involved in pathogenesis is dopamine receptor hypersensitivity. Though in studies, they have found out that the premonitory symptoms, the prodromal symptoms, were responsible in the dopamine was responsible. Therefore, treatment against dopamine will also be effective in case of migraine. The third, lastly, is the genes involved. Genes Mutation in genes leads to alteration of the membrane excitability. Three genes have been identified. The first is CACNA1A gene, which leads to familial hemiplegic migraine type 1. The second is ATP1A2, which is associated with sodium potassium ATPase pump, leads to familial hemiplegic migraine type 2. The second is SCN1A, voltage gated sodium channels are getting involved, which leads to familial hemiplegic migraine type 3. So here in the image we can see this dura mater is having this meningeal vessels. Meningeal vessels are getting supplied having this trigeminal. This is a trigeminal nerve, trigeminal nucleus, trigeminal nerve, ophthalmic, maxillary, and mandibular branches, which supplies this blood vessel. So therefore, this trigeminal vascular input is the main thing which receives the signal of pain. Then from the trigeminal nucleus, the fibers run up to the thalamus. As I said, thalamus is a relay center, and from thalamus, then the third order neuron will start and will uh, supply the somatosensory cortex, and the pain will be perceived. Diagnostic criteria for migraine. So, Harrison says there must be at least two of the following features, which includes unilateral, throbbing pain aggravated on movement, which must be moderate to severe in intensity. If any two of these features are present, plus any one of these features, such as nausea, vomiting, photophobia, or phonophobia, will tell us that this patient is having migraine. So, as I said, migraine is an episodic headache lasting for 4 hours to 72 hours. in patients with normal physical examination and no other reasonable causes. As we will learn in our next video, which is going to be about tax, there will be as high as 200 episodes of headache in a single day. That is how frequency of headache and intensity of the headache is important. So for that we must advise our patients to maintain a headache diary in which the starting of the headache and the duration of the headache with their frequencies must be maintained, so therefore we can get a clear idea and we can easily differentiate. And also, migraine has to be differentiated from tension type headache and tax. So this was our diagnostic criteria. Plus, as we have discussed, that prodromal phase, headache phase, and uh, postdromal phase. These are the symptoms with which the patient is going to present. So, putting all together, we are going to diagnose this patient as having migraine. Now, uh, as far as the treatment goes, first and the foremost part is non pharmacological therapies, which includes avoiding triggers. Explaining the adversities related to the triggers is a must, and patients should be advised on how to tackle those conditions. Secondly, managing acute attacks of migraine. Acute attacks of migraine can be debilitating, very severe in nature. It at times it is said that migraine attacks ultimately affects a person's professional as well as a personal life. Professional in the sense the migraine attacks are so painful that the patient will not be able to perform his daily routine activities, even he will not be attending his offices and take leaves uh, related with headaches. He will assume he will prefer staying at home only and sleep. So this is how acute attacks of migraine are, and we must understand how we are going to treat it. In our armamentarium, we have simple analgesics and NSAIDs. These two classes of drugs are useful for mild attacks of migraine. Though for severe and moderate intensity of migraine attacks, we have these classes of drugs, in which first is 5-HT1B1D partial agonist, which is our triptans. So triptans are available in parenteral form, oral and nasal form. For acute and severe migraine attacks, we prefer parenteral form, in which we give sumatriptan 3, 4, or 6 milligrams subcutaneous at the onset. It can be repeated after 1 hour if needed. Also, this other drug, which is ergotamine, which is dihydroergotamine, 1 mg, it can be IM, IV, or subcutaneous, can be given and can be repeated. With respect to these two drugs, we must understand its mechanism, because with patients with coronary artery disease or say uh, peripheral vascular diseases, these drugs are not going to be used, they are contraindicated. So, our first drug in armamentarium is the triptans, which are going to be useful in acute attacks. The second is CGRP receptor antagonists, GPANTs. This is a newer modalities coming into a treatment of migraine, which have proved and they have changed the landscape of migraine treatment. They are very efficacious. This includes the remagepants and ubrogepants. Remagepants for acute migraine attacks, we prefer 75 mg orally disintegrating tablets. Ubrogepant 50 to 100 mg per hour. Then the third, this is the interesting part, 5-HT1F receptor agonists, which are ditans. Example, lasmiditant. See, with respect to 5-HT1B1D receptor agonist, these are going to act centrally also and peripherally also. They have neuronal mechanisms plus vascular mechanism. But this 5-HT1F agonist has only neuronal activity. Therefore, this drug does not have peripheral side effects. Hence, this drug is useful for patients having coronary artery diseases or peripheral artery diseases. So, we must keep in mind treating any patient with acute attacks of migraine If the patient is at risk of having cardiovascular mortality, we are going to avoid these drugs and prefer 5-HT1F receptor agonists. Then dopamine receptor antagonists. As we have learned in the pathogenesis part, dopamines were responsible for the prodromal stages. Then again, these are useful for acute attacks, which includes metoclopramide, chlorperazine in oral and parenteral forms. Doses we will see in the next slide. Then the group is opioids. Then neuromodulators. Neuromodulators have been reserved if this first acute therapies are not beneficial. Neuromodulators will include non-invasive vagal nerve stimulation and other uh, mechanisms. We'll see in a while. So, but then migraine therapies must be individualized. As far as the profession of the patient goes, the duration of the attacks, the frequency of the attacks, and the these all drugs also has their own side effects. Therefore, the migraine therapy must be individualized according the patient's comorbidities. So this is the whole acute treatment part of migraine. Treatment of acute migraine, we have simple analgesics and NSAIDs with the doses given. This we are going to reserve for mild attacks. With acute bouts, which are severe in nature, we have triptans, which can be oral, nasal, parenteral. Sumatriptan, as we have learned, 6 mg subcutaneous at onset can be repeated after 1 hour. So this is our go-to drug if the person does not have any comorbidities of cardiovascular mortality. The second group, which is interesting, is the CGRP receptor antagonists, which includes GPANs. Orally, rimagepant and ubrogepant, we have learned in the previous slide. 5-HT1F receptor agonists, this is DTANs. DTANs, as I said, are very useful. They does not have peripheral actions, hence they are useful in patients with cardiovascular risks, uh, which is lasmiditan. Okay. Then dopamine receptor antagonists such as metoclopramide and chlorperazine. So that is all what I needed to say. That triptans uh, are useful, but they are contraindicated in patients with CAD, stroke, and peripheral vascular diseases. Ergotamine is less selective. Triptan was a 5-HT1B1D receptor agonist, but ergotamines are less selective and they have more side effects. It leads to potent and prolonged vasoconstriction and therefore must be avoided in patients with uh, severe risks. So, in those patients, prefer detents. Safe in coronary artery diseases, it has purely neuronal actions and no vasoconstriction. Then, with respect to neuromodulation part, we had a single pulse transcranial magnetic stimulation. Image I am going to show you in the next slide. Non-invasive vagus nerve stimulation. So, this is a handheld device, non-invasive vagus nerve stimulation. Two doses each of 120 seconds. Okay, so 2 minutes and two doses. So it is going to effectively hamper the acute bout of migraine. Then third is remote electrical neuromodulation, transcutaneous supraorbital nerve stimulation. These are all FDA approved neuromodulation techniques, which are non-invasive in nature, which are drug free, and therefore they have been accepted and used. Preventive therapies for migraine. Uh, for First of all, the patients who are in need for preventive therapies are the ones who have 4 migraine days per month. They are going to be characterized in having chronic migraine, and the classes of drugs with which we can prevent these migraine attacks are beta blockers, antidepressants, anticonvulsants. Then again our star molecule, CGRP pathway blockers, which includes monoclonal antibodies to the receptor and the molecule itself, and CGRP receptor antagonists. So these monoclonal antibodies, eptinezumab, erenumab, fremanezumab, and calcanezumab, these are all going to be parenteral in nature, maybe once a month or uh, once a week kind of a thing, and they are going to be very very effective in prevention of migraine attacks. Again, rimegepant and atogepants are going to be our CGRP receptor antagonists. So once daily dose of atogepant is being used. And again, neuromodulation techniques for preventive therapies, which we have uh, learned in our previous set. Okay. So lastly, the table from Harrison's, which includes the preventive treatment for migraine. We have beta blockers such as propranolol and metoprolol. Using metoprolol, we must consider that it is contraindicated in patients with asthma. The doses is been given here. Antidepressants and anticonvulsants. So uh, basically, these all drugs are going to be used for the preventive therapies in migraine. If not, the patient being managed on these drugs must be considered for CGRP pathway blockers such as eptinezumab, erenumab, galcanezumab, which are going to be 100 to 300 mg IV every 12 weeks. So for with galcanezumab, it is going to be 240 mg loading, then 120 mg monthly subcutaneous. These are going to be all parenteral monoclonal antibodies. They are having a very good result. And lastly, neuromodulation techniques. So this is a single pulse transcranial magnetic stimulation device, which is FDA approved drug-free therapy, and it is being used for preventive therapies. This is a non-invasive vagal nerve stimulation technique, as we have learned for acute management. Two doses of 120 second each will be enough for terminating the acute attack of migraine. So this was it, guys. Thank you for listening me. Thank you so much.